Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pern, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end. This podcast is sponsored by Invivo Healthcare, the human microbiome company restoring human health and ecology with seamlessly connected testing, supplements and education. The Invivo team of scientists and practitioners work alongside healthcare practitioners to expand their expertise. As pioneers in testing, Invivo Ecologics range delivers a unique insight into the gut, vagina, oral and urinary microbiomes with unparalleled detail and accuracy. Their supplements are crafted using live commensal cultures and selected botanicals and designed with specific microbes in mind for a truly targeted approach. Invivo is a go-to in my clinic for microbiome testing and supplementation. For more information, visit invivohealthcare.com. Hello, it's lovely to have you here today. I am joined by Irfana from IVF Matters. And IVF Matters are a private fertility clinic who work in central London and also do telehealth, not telehealth, telehealthcare across the country and around the world. So Irfana, welcome to the show. It's lovely to have you here today. Can you tell us a little bit about your background and about IVF Matters?
Yes, certainly, Hannah. Lovely to be with you and to share, my experience with your audience. So in terms of my background, I'm a gynecologist. I then specialized in fertility medicine. I trained at King's College Hospital in London, and over the last 18 years, I've been supporting individuals who want to preserve their fertility by freezing their eggs, sperm or embryos, and also those who want to start a family or grow their family. So that, in a nutshell, is what I do, and my background. But in addition, what we are also able to do is support those who've just started their journey and just want to optimize their chances of conceiving. So we are able to do ultrasound scans across the country using our partner clinics at over 80 locations. We are also able to do laboratory tests across the UK. So with that, I believe we can make an online diagnosis for anyone who wants to learn about their fertility health or is having a delay in getting pregnant.
Okay, great. And today you have very kindly given up your precious time to talk to us about physical investigations for women's health and for fertility. And the reason I asked you to come on and talk about this is because I feel that people who message in the show and people who I see in clinic are often really confused about what their options are and what's available. And so I just thought it would be great to get your insight into what the different types of scans are, what are they doing, who they are appropriate for, how do you go about getting them. So that is the topic of the show today. So let's start at the very beginning. Well, I feel like this is the beginning because this is kind of like what I see as like the first line physical investigation that lots of people are offered, and that is a transvaginal scan. So am I right in that assumption? And if I am, like, what is a transvaginal scan? What's it doing? Why are people offered that when they begin to look into their fertility?
So it's a very good question, Hannah, because I believe that unless those who are undergoing their diagnostics understand the value of it and what's going to be done, it's very hard to commit to a process which is essentially elective. So, as you said, the first step in understanding one's fertility is to know about, how the ovaries are working, if there are any lumps or bumps in the uterus, is everything inside looking okay? So, a transvaginal scan is an internal scan where the assessment in terms of the follicle count or the egg sacs is made. And that is an indirect reflection of ovarian function. So typically, one would expect to see 7-8 follicles in someone whose ovaries are working well. So a total count of 14 and above follicles in both ovaries would be considered a good count. Then the uterus is also looked at. So we check the size, the dimensions of the uterine cavity, the shape of the uterus to make sure everything inside is healthy. There's no abnormality or any shape defect. And then you want to assess that there are no soft tissue swelling, so things like polyps and fibroids. The first step, which is the fertility scan, is quite an essential and important part of the puzzle, because that gives you a lot of information. So, for example, in women who have endometriosis, you'd often see cysts in the ovaries, and that would give you information, and it'll prompt you to start investigating along those lines.
Okay, so that's interesting, because often, we're told that endometriosis cannot be diagnosed from a transvaginal scan. So is it that you could get some signs that might indicate endometriosis? Because I always think of endometriosis as being outside of the uterus rather than inside. So you're saying that there are some indicators.
Yeah. So what happens in someone who has endometriosis, they may have fluid-filled areas in one or both ovaries. And often this is filled with blood in it. And as time passes, there is a very characteristic appearance that you see when there is endometriosis in these cysts. Equally, what happens is that because the cells that line the inside of the uterus are spilled into the pelvis, in someone who has endometriosis, these little spots bleed every time you have a period, and they secrete sticky fluid, which means that in those who have more severe type of endometriosis, you'll find that it's very difficult to move the uterus. Things seem to be quite stuck.
Okay.
So that's also an indirect reflection. Specialists who have a lot of training can also pick up very small endometriotic nodules in the pelvis. So these are all, markers which would suggest that, someone has endometriosis. And of course, the clinical background and, their symptoms will also aid in the diagnosis.
Okay. And for the transvaginal scan, is there a particular time in a person's cycle that they should go for this scan, or can you go at any point during your cycle?
So it depends on why you're having the scan. If the intention is to check the follicles, then ideally, at the start of the cycle is considered most appropriate. And if you're just having a scan to check your, the health of the uterus, you could, of course, do it at any time.
Yeah.
So it depends on the indication. But generally, if you do the scan at the start, then you'll get all the information you need. And hopefully that means you don't have to keep going again.
And just going back, just thinking off the top of my head, going back to what you were just saying about endometriosis, I've worked with lots of people in clinic who've been told they've had a transvaginal scan and they've been told you have not got endometriosis on the basis of one transvaginal scan. Is that okay?
So, many women will have mild endometriosis, in which case you won't pick it up on a transvaginal scan. So it is likely that in mild cases, you don't see any cysts in the ovaries. You'll find that the uterus and the ovaries are moving fine. There are no endometriotic spots either. Now, the thing is that if someone has mild endometriosis, generally it does not affect their fertility. So there is no real need to try and investigate everyone, whether they have endometriosis or not, by putting a telescope in their tummy, because that's quite an invasive way of assessing. So if you've got mild endometriosis, generally, you won't have many symptoms. When you do an ultrasound, it all comes back as normal. So although you have endometriosis, it won't be very obvious.
Yeah.
In which case, actually, no further action is needed. So, you don't need to worry about it. But
Yeah.
of course, the ones who have more severe type of the problem will generally have, excruciating pain when they're in a period. And when they do the scan, you'll find that, they have some of these features. And of course, they are the ones who will need to, take further action and try and resolve this by, undergoing a surgical intervention.
Okay. So transvaginal scans are the first line. Then often what I hear is that people then go through the system and maybe if they're preparing for IVF, certainly on the NHS, lots of people seem to then have a HYCOSY. Have I said that correctly?
You have, yeah. So what I'll do, Hannah, is if you don't mind, I'm just going to actually explain what's involved in getting pregnant.
Okay, yeah, go for it.
We can then try and, understand which test is needed.
Okay.
Based on that information. So that's what I do generally in clinic. I just
Okay,
explain
let's do that.
natural conception.
Yeah.
And then when we talk about everything else, it just seems very obvious and just makes a lot of sense.
Okay.
So typically what happens is that the ovaries produce an egg sac or a follicle, and one of these starts taking the lead, so that roughly about 2-ish weeks into the cycle, it's reached a good size of about, 18 to 20 millimeters. And that's when it bursts and the egg is released. Now, if you're having unprotected intercourse, the sperm get released at the neck of the uterus. They then start swimming in the direction of the egg. So the egg and the sperm meet in the fallopian tube, and that's where fertilization takes place. And once the egg is fertilized, it's now called an embryo. And the embryo starts dividing really rapidly, so that in 5 days' time, it has about 100 cells in it. And it's now called a blastocyst. So once it's reached that stage, the embryo has made its way into the uterus and finds a place to embed. So to summarize, you need an egg to be produced from the ovary. The egg and the sperm need to meet in the fallopian tubes for fertilization. And then the embryo starts developing and slowly makes its way into the uterus and embeds. And that is called implantation. So once the embryo is embedded and it's found a nice place to stay, it then sends a signal to the body and you therefore don't get a period. But if there is an embryo, but the embryo hasn't found a reasonable spot to embed, then although there's an embryo, there is no pregnancy. And that's when you start getting a period. So in order to get pregnant, you need your ovaries to be working. You need at least one, ideally both fallopian tubes to be open. The uterus should have a very regular cavity from the inside. So polyps and fibroids make the inside environment of the uterus unhealthy. It also leads to inflammation. So all of this prevents the embryo from embedding. And then, of course, you need sperm of equally good quality. So in order to assess what's causing the delay, if you're trying to conceive or if you just want to know about your the health of your reproductive system, you've got to assess each of these structures that take a part in conception. So that means you've got to check your ovaries, your fallopian tubes, the uterus, the sperm, and also you've got to both be in good overall health. And for women, your thyroid plays a role, your vitamin D levels play a role, and you should be immune to rubella, not because it prevents you getting pregnant, but you want to protect the baby. So these are some of the basic checks.
Mm-hmm.
Now, so far, we spoke about how the fertility scan assesses the ovaries. What I'm now going to do is talk about the other structures which are involved, which is the tubes and the uterus. So in order to assess the tubes, we inject dye from down below. Now, this can either be done under ultrasound guidance, and that procedure is called a HYCOSY,
Mm-hmm.
or it can be done under X-ray guidance, and that procedure is called an HSG.
Mm-hmm.
Now, the HSG is what is and has been traditionally offered on the NHS, although no doubt many NHS clinics are now also offering the ultrasound-guided test, which is the HYCOSY. So basically what is done is that a tube is passed through the neck of the uterus, and the first assessment is done of the uterine cavity. So saline is injected, and you then take 3-dimensional images and you assess the uterus to see for any fibroids or polyps protruding into the uterine cavity. Now that test is called a saline scan.
Okay.
Now, as soon as you've finished injecting the saline, you've taken all your images, you then inject the dye to check the uterus. So it happens one after the other. So in the same appointment, you get your uterus and the tubes checked. So once you've injected the dye, you then see for flow on either side. And that tells you whether the fallopian tube is open on one side or both sides. So the saline scan and HYCOSY happen in the same appointment, one after the other, and it assesses the uterus and the tubes. Now, if someone's undergoing IVF treatment, because in IVF treatment, you're bypassing the tubes, you don't really need to do the HYCOSY test. You only need to assess the uterus because that's where the embryo is going to be released. So if someone's undergoing IVF treatment, they don't really need to assess the tubes unless you're not sure what treatment you need, because there is another type of treatment called IUI treatment, where the sperm is filtered in the laboratory and then just released in the uterine cavity. And that's like falling pregnant naturally because the egg and the sperm still have to meet in the fallopian tube. So for those who are having IUI treatment, they need to ideally know whether their tubes are patent or not. And they are the ones who would have both. Or if you aren't sure as to what is the reason why I'm not falling pregnant, then too, you would want to do both. But if, say, for example, you knew that your partner's sperm quality is such that you 100% need IVF treatment, then there is no need to check the tubes. You would only then check the uterus.
Yeah. Yes. And what about those? Because a thing that I see a lot is that lots of people go for IVF without a reason why they don't know that, unexplained infertility is a common reason. And often there seems to be a lot of people who go for IVF, unexplained infertility, who still haven't had a HYCOSY because they haven't had their fallopian tubes checked, because obviously the IVF clinics are like, well, you're having IVF now, so you don't need to do it. And I often think, well, maybe that is the reason why, maybe that investigation, because might be warranted, because it could be to explain why they haven't conceived. So I find it sometimes, and I think patients too would say they feel a bit confused why that test hasn't been done and why it's not done more often.
Yeah. So I'll tell you what, you've hit the nail on the head, where this is the bit that I pay a lot of attention to when I'm investigating a couple, where I really try and understand what's causing the problem. Especially for, if you're a young couple who've been trying for a year, you would expect 85 out of 100 couples to fall pregnant. And if they've been trying for 2 years, 95 out of 100 fall pregnant. Now, generally, at least traditionally, most couples come to a fertility clinic once they've been trying for at least a year or two. Although I'm seeing a shift wherein I'm seeing more and more young couples who even haven't started trying, but they just want to understand where they are, even in the preconception phase. But I generally don't like starting treatment unless I've done all the basic checks and tried to understand what's caused their delay. Because if you just blindly have IVF treatment, it doesn't fix the problem. Because, for example, if there's low sperm quality, there's high DNA fragmentation in the sperm, by just doing the IVF, you're not going to address it. And if anything, your chances that the treatment won't work are quite high, and the risk of miscarriage is quite high. And likewise, if you've got a polyp or a fibroid in the uterine cavity that you don't know about, and then you've released an embryo, which is so precious, and if it does not stick, you won't know why you didn't fall pregnant. And you're going to wonder because you go away thinking, but it was a very good quality embryo. So why did I not fall pregnant? And once you've undergone that heartache of, having the full cycle of treatment, you've invested emotionally, financially, and then if you don't fall pregnant and realize in retrospect that actually I did have a polyp or a fibroid, it's too late in the day to try and fix it. Because the embryo that you've lost, you're not going to get it back. But at least had you known, you could have, got the polyp removed, had the fibroid taken out, and then, you would have had the best shot at it. So, my personal take on anyone undergoing fertility treatment is to, and understand within, a sensible kind of approach. I'm not suggesting that you do every test under the sun, because equally you don't want to, just lose track of what you're trying to achieve. But at least if you've done the checks and you have an understanding of either the tests have all come back as normal or you've picked up a problem, you then need to address it. So, if the sperm quality isn't great, you need to try and understand what can be done to improve it. Otherwise, it just is a tick box activity. You'll just undergo it. And if it doesn't work, it's, once you've had one or two rounds, with most couples, they just won't have any energy. And in most cases, they won't financially be able to afford more treatment. So it's so critical to get it right.
Yeah.
And not to just rush and feel so much pressure that you feel, oh, I just have to keep going. Because yes, you do have to keep going, but you have to keep addressing what is found. Otherwise, what's the point if you know, for example, that, there is fluid in the tubes, and we know that this fluid can backtrack into the uterus and make the environment unhealthy for the embryo to embed. So if you don't remove the tubes and you just have an embryo transfer, you've already put yourself, at a disadvantage. So I feel a very systematic approach is more sensible. What you eat, your BMI, all of these are such important factors. But what I see every day is patients are under a lot of pressure to keep going. And because, clinics understand that the patient wants to carry on, there is very little emphasis on doing this diagnostic piece. So I was really pleased when you asked me to talk about this topic on diagnostics, because actually this is the essential bit.
Yes. And am I right? Because I often hear people say that, there is some evidence around being more fertile after a HYCOSY. Is that just anecdotal or is that actual science?
No, it is true, because what happens is that, when you put fluid under pressure, sometimes, if there's a little bit of debris in the fallopian tubes, you are flushing the tube. So there are research papers which have indicated an increase in conception after doing a tube test. And I have seen it over the years.
Yeah.
Where my patients have had the tube test and then they've fallen pregnant because, clearly that has helped in some ways. So no, it is for a fact.
Yeah. Okay. So it's definitely something to seriously consider as part of your fertility
100%.
journey. And with the saline scan, can I just ask, is the purpose of the saline am I right, to kind of like unfold the uterus so you can see it more clearly?
Yeah.
Because even though, it's not very helpful on radio, but whenever we see uteruses, we see this kind of like triangle shape, don't we? And we think, oh, there's this like cavity of triangle, but it's not like that, is it? It's like folded together.
Yeah, it's like a collapsed bag. So the inside of the uterus is like a collapsed bag. So unless you put some fluid and you distend it, you can't see what's protruding in it.
Yes.
Now, just to give you an idea, the polyps can sometimes be just 2-3 millimeters. They're really tiny. And you won't pick them up if you do a 2-dimensional scan. And if you think about it, if the 2-dimensional scan were to always pick up little things like polyps or even a very small fibroid, then why would we need to do the saline scan for anyone?
Yeah.
And also when there is a little bit of scar tissue in the uterus, you won't pick it up when you do a 2-dimensional scan.
When you say 2-dimensional, are you meaning transvaginal, like a standard transvaginal scan?
Yeah,
because you don't see that kind of expanse of the uterus wall because it's like collapsed in.
Yeah. Even if you do a standard 3-dimensional scan without putting in a saline, you won't pick up everything. So the debate is whether you should do a 3-dimensional saline scan or whether you should subject yourself to putting a telescope, which is the gold standard, and it's called a hysteroscopy. But the thing is that when you're putting in a telescope, generally it's done under a general anesthetic, although it does not have to be. There are some clinics who do it as an outpatient, but the risks attached are more because there is a small risk of injuring the inside of the uterus and the telescope passing through the wall of the uterus, what we call a perforation. So there's higher risk. And what I tend to do is I do the less invasive test, which is the saline. And of course, if the saline picks up a problem, then you need to be booked in to have the polyp or the fibroid removed. So you're also more prepared when you then do the hysteroscopy in terms of understanding what's going to be done. Because otherwise, what happens is if they put the telescope and you haven't been told that there's a polyp or a fibroid, the surgeon may not be able to actually carry out the procedure because you've not consented to it.
Right.
So why have 2 invasive procedures twice? You'd rather do like a screening test, which is very accurate. And if that's clear, then there's no need to do a hysteroscopy. But of course, if there is an underlying reason, so say you've had multiple attempts and it's not worked, or there is other medical history where you feel actually, you do need to have a hysteroscopy because the suspicion that there is a polyp or a fibroid is very strong, then that's different.
So you'd start with a saline. So a saline scan can be done without being under general anesthetic.
Yep.
It's a straightforward procedure. Do you take painkillers or any kind of anesthetic?
You just take some pain relief like paracetamol or Nurofen.
But so that's more of an in and out procedure.
Yeah.
And a hysteroscopy is obviously more intense.
It's a day care.
Yeah. And so we see a lot of people in our clinic who have hysteroscopies because of scar tissue issues around maybe miscarriages or endometriosis, things like that. So can you tell us a little bit more about hysteroscopies? Because I've seen quite a few people who've had repeat implantation failures, and then they go and have a hysteroscopy and they find that there's an issue that was never picked up previously. And again, it's like, it's always the debate about at what point do you have this done? I guess the question I'm asking is, what are the flags for a hysteroscopy other than you've had a saline scan and that might have picked something up? Is there anything else in people's kind of histories or journeys that makes you think, okay, what we need to do is a hysteroscopy in this case?
So what happens is if you have a uterine septum where there is, a little extra bit of tissue in the uterus, and that you can pick up on a 2-dimensional scan. So the scan has already picked up the fact that you have a septum. Then there's no need to have another test to tell you what you already know. Then you just need to have that septum resected, in which case you'd have the hysteroscopy. Or if you've done the 2-dimensional scan or even the 3-dimensional scan, and if you picked a polyp or you've picked a fibroid, then you wouldn't do another test to tell you the same information. Or, if you've had multiple miscarriages or you're having, multiple attempts at embryo transfer, which aren't successful, because when you do the hysteroscopy, you can even scrape the inside of the uterus and send that for testing. So those are some of the reasons why you would, do the hysteroscopy, and you may not necessarily do a saline scan.
Okay. And what about for people who've got scarring? They've got the scar tissue, or let's say, for example, you've got a thin uterus lining that does not get thick.
Then you should have a hysteroscopy.
Yeah. So and why are they having a hysteroscopy in that situation? Because they're looking for reasons why the uterus lining isn't thickening up.
Yeah. Because what happens is that, one of the reasons why the lining isn't thickening is because there is scarring. So that's when you want to put in a telescope, because it can then fix the problem at the same time.
Okay.
So you see, the advantage of a hysteroscopy is that if there's a very high suspicion that, yes, there is scar tissue, or yes, there's a polyp, then you can not only see the problem, but also fix it. Whereas when you do a saline scan, it's a diagnostic procedure. So you can't fix anything. You can only see the problem and say, yeah, this is what I see. I'm seeing the polyp, I see the fibroid, but you can't address it. So both procedures have their pros and cons.
Yeah. And so the other question I'm always confused about is some people that I've worked with have MRIs. So rather that they have MRIs, especially people who've got like severe endometriosis or very complicated anatomy, they often have had MRIs to diagnose scar tissue. So why MRI and not hysteroscopy in those instances?
So if you are suspecting quite widespread endometriosis, for example, then the MRI will tell you about the pelvis. Now, this also depends on the expertise of the person doing the ultrasound. So if the person doing the ultrasound is able to pick up these small endometriotic nodules and can tell you about the extent of scarring because of the restricted mobility, can give you fairly accurate information about the cyst in the ovary, what the dimensions are, how many there are, then you would do an ultrasound. But if you don't have the in-house expertise, then most clinics would just do an MRI. It really depends on who's doing what, and it depends on what you have access to.
And in your opinion, what's the best to get the best information or the most precise information? Because the other thing that I would say that I've seen a lot is people have repeat hysteroscopies and with different information. They might have had one on the NHS, then they have one private, and one said, yeah, absolutely fine, and the other said, actually, you've got scar tissue. There's it feels like it can be quite different opinions depending on who's doing the hysteroscopies. Like, which is the best way to get a consistent picture of what is actually happening?
So one of the things I would like to point out is that, generally both the procedures would not have been done at the same time. And therefore, it's possible that the information was true at the time.
Okay, yeah.
And although you're seeing it as being inconsistent, actually, when the first hysteroscopy was done, there was no scar tissue. But, 2 years later, there was a miscarriage, there was an infection. So the story may have changed. So that's the most important thing to bear in mind. Generally, I don't know anyone who would have had 2 hysteroscopies in a very short period of time. Generally, the time interval is quite significant. And that may be playing quite a big role, because, a polyp can appear anytime. I've seen patients who've had treatment, everything's been fine. They've come back to have another child, and then we've picked up something else. But it's not that we didn't pick it up previously. It's just that it wasn't there. This is something new that's come up.
Okay.
So that's important to keep in mind. But I think importantly also what happens is that the expertise of the person, the equipment used, and the quality of the equipment will also play a role. So if you have an ultrasound machine or a hysteroscopy or a hysteroscope which is of very high quality, it will see more than somebody else's equipment which just does not have the ability to, because you're using a more later version of that equipment. So it won't be fair to compare. I think a easy way to look at and compare is, especially in the fertility world, you've got patients who are having IVF treatment, for example, and their embryos are being kept in incubators. And some clinics have incubators which have a camera attached in it called an embryoscope. So you could, say, but they're both incubators, but there's one incubator which you are using only to preserve your embryos, whereas there's another incubator which is preserving your embryos, but is also continuously taking images, so you know what's going on and how the embryo is developing. So although it may seem like the same thing, it's not.
Yeah.
Because there's a distinct advantage with the incubator that has a camera in it.
Yes.
So that's the same thing. When you go to any clinic, your outcome also depends on the expertise of the staff, the equipment they're using, what is the experience. So, all of that will play some role.
Yes. And that's interesting, isn't it? Because we see quite a big difference between what people are told just by a transvaginal scan, depending on who's done the transvaginal scan and what equipment has been used. And so you sort of assume that it's the same, but it's not, because it depends on exactly the skills, the expertise of the person doing it, the type of equipment they're using, and you can get very, very different information and results.
Yeah. And can vary quite significantly. And I think, that's where every little thing will add up.
Yeah.
So you've got to, keep that in mind, because if there's a clinic, that's offering you what may seem like a treatment which is significantly differently priced to another clinic,
yeah,
there is a good chance that it's not exactly the same. Although it may be called IVF, it's not exactly the same.
Well, I tell you, Irfana, that has been an amazing, enlightening and insightful romp through all of the fertility investigations, because, it's something that we are asked about all the time in clinic. And there does seem to be a lot of kind of confusion about what you could do next, how you could investigate, like where to go. And so it's really good to have it broken down like that. It's really, really helpful. So thank you very much for your time today.
It's been a pleasure. And I hope that, anyone listening to it will go away feeling really hopeful, knowing that there are things they can do to improve their outcome. And, it's important to keep the faith.
Yeah. Thank you.
All right. Lovely. Good speaking to you guys. Take care.
Bye. We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.